Welcome back to Breathe Easy. Last episode, we broke down what inhaled TXA is and where it fits in your clinical toolkit. But now, we're done talking theory. This is the action episode. Episode 24 is about what you actually do when inhaled TXA is ordered. And the room is looking to you for direction. We're building a repeatable bedside workflow so when the pressure's on and blood is in the airway, you don't freeze, you flow. And in this episode, we're also going to get very practical. We're going to talk about how you actually deliver this therapy. Flow, setup, device choice, because in a real airway bleed, those details matter. Here's your framework. Verify, set up, deliver, and evaluate. 4 moves, that's it. When the room gets tense and everyone's talking at once, this sequence is your anchor. But inside each of these steps are key technical decisions. Is your setup correct? Is your flow appropriate? Can the drug actually reach the airway? Because if those pieces aren't right, the therapy fails. Even if you followed these steps, this is what turns reactive treatment into intentional clinical decision making. Step 1, verify. And I don't just mean the order. You're verifying the patient in front of you. The question is simple. Do we still have a window? Is the patient still stable enough for inhaled therapy? You should be asking, are they protecting their airway? Is oxygenation stable enough for a nebulized treatment? Or are we moving toward intubation or bronch? Because if they're crossing into an airway emergency territory, this workflow changes immediately. If we've lost the window, there is no longer an inhaled TXA conversation. Step 2 is setup, and this is where success or failure is decided early. Delivery doesn't start when the nebulizer turns on. It starts with how you build the setup. Let's talk details. If you're using a small volume nebulizer, your target flow is 6 to 8 liters per minute, enough to generate consistent aerosol, not so high that you blow the medication past the airway. If you're using a mesh nebulizer like Aerogen, it does not require added flow to generate aerosol. Flow is determined by the patient's oxygen setup. These are often preferred in ventilated or high acuity patients for better deposition. Now, match your interface to the airway, mask, mouthpiece, or inline ventilator circuit. If there's a significant bleeding, a mask may not be tolerated. If intubated, ensure proper inline placement, not an afterthought. Then think about positioning. If you know the bleeding side, consider placing the bleeding lung down, because if the medication can't reach the airway, it can't work. And this is one of the biggest practical pearls in the series. If there's an active blood or secretion burden, suction first. And I mean intentional airway prep. You're thinking Yonkau versus inline suction. Is there a clot burden? Can I actually clear this path? Because TXA doesn't dissolve clots. It stabilizes bleeding. If you're delivering medication into pooled blood, it is not reaching the tissue. Clear the airway so the drug can actually hit the target. This is the difference between giving a treatment and making it work. Step 3, deliver. But here's the rule. Do not walk away. And at ECU Health and Outer Banks Health, we stay with our patients. This is not a set it and forget it nebulizer. You are actively managing a potential unstable airway in real time. While the treatment is running, you're watching work of breathing, visible bleeding, oxygen saturation trends, patient tolerance, and also check your device. Is the mist actually being generated? Is the chamber emptying? Is your setup intact? This is active care. You are not passive in this moment. Stay at the bedside and be present. While the treatment is running, you're gathering real-time data. You're asking, is the bleeding improving, unchanged, or getting worse? Is oxygenation stable? Is the patient tolerating the therapy? And here's how that translates clinically. Bleeding decreasing, continue and reassess. No change, consider repeating the dose or escalation. Worsening, this may no longer be a medical management. And here's the key. Even if the bleeding looks better, if oxygenation is dropping, that changes your decision making. Watch the trend, not just the moment. Step 4, the treatment isn't finished when the neb stops. Reassess and communicate clearly to the team. This is where your clinical voice matters. Don't say it looks better. Say bleeding decreased during treatment, oxygenation remains stable. Or no change after the full dose, patient tolerated the therapy. Or bleeding is worsening, I would recommend escalation of airway management. Improved, unchanged, or worse, say it clearly, because that communication drives every next decision: repeat dosing, escalation, or definitive care. And this is where your identity as a respiratory therapist really shows up. You're not just administering medication, you're assessing, recognizing, and guiding the next step. You determine if the window is still open. You evaluate how well the therapy was actually delivered. Because if the setup wasn't right or the airway wasn't prepared, that changes whether this treatment failed or was never given a fair shot. That's what makes this RT-driven care. Inhaled TXA isn't just the medication, it's how you apply it in the moment that matters. Verify the patient, set up intentionally, stay at the bedside, reassess clearly, and understand this: right patient, right setup, right flow. That's what determines whether this therapy actually works. That's your workflow, that's your rhythm. Next episode, we go deeper into safety and dosing and what to watch for when things don't go as planned. Until then, keep your airways clear, your instincts sharp, and your flow steady, because when the pressure rises, you don't hold your breath, you lead with it, and you continue to breathe easy.